for sticking around. I know your conference is almost over and there are a lot of good things to do on Saturday. This was a fun talk to put together. We're going to talk about community-acquired pneumonia because the new IDSA CAP guidelines just came out in the last 2 weeks, and I will tell you that the speakers for this course were required to have our talks in like 4 weeks ago or something, and I'm not usually exactly on time with that, but this year I was. And then literally on October 1st, the new CAP guidelines came out, so I told Bob I had to redo my talk, and I was penalized for being early in getting my slides in. But anyway, so we're going to talk about the new CAP guidelines that literally just came out. We're going to talk a little about some updates in hospital-acquired pneumonia, and those guidelines came out a couple years ago. We'll talk a little bit about aspiration pneumonia in terms of choosing antibiotics. I think this is a really common topic in hospital medicine. And then we're going to talk about influenza, both diagnosis and treatment. And influenza is one of my favorite diseases to talk about. So by the end of this talk, you'll be able to list the major updates in the new CAP guidelines, recognize the appropriate antibiotic regimens and duration of therapy for hospital-acquired pneumonia, and then construct an antibiotic plan to treat aspiration pneumonia, and describe the key principles in diagnosing and managing influenza in the hospital. Okay, so let's start with the case. 75-year-old man with diabetes, CAD, COPD, and ESRD on dialysis, admitted from an assisted living facility in June for fever and cough. His last hospitalization was for a hip fracture 6 months ago. He's febrile to 38.4, he has a respiratory rate of 20, he's satting 92% on 2 liters. His white count is 18 and otherwise his labs are normal, and his chest x-ray shows a right lower lobe consolidation. So that's a lot of information. What antibiotics would you start in this gentleman? Ceftriaxone plus levofloxacin. Sorry, it will convert to the correct numbers in the ceftriaxone plus azithro, vanc plus ceftriaxone, or vanc plus piptazo. All right, so most of you said ceftriaxone plus azithro, and then about 20% vanc plus piptazo. So we'll come back to this in a second. So what was the key factor in choosing his antibiotics? So was it that he lives in an assisted living facility? Was it that he's on dialysis? Was it that he has a hip fracture 6 months ago and was in the hospital? Or is it that he had a lack of risk factors for MRSA or Pseudomonas? Okay, so a similar split. Most of you said lack of risk factors for MRSA or Pseudomonas, and then some of you said lives in an assisted living facility and on dialysis. So just to backtrack to the first question, I think the most correct answer is what most of you said, which is ceftriaxone and azithro, and I think the reason for that is because he has a lack of risk factors for MRSA or Pseudomonas. So we're going to kind of go through this in detail in terms of how to think about choosing a regimen and what the new IDSA guidelines say.